I'm Dr. Andrew Elkwood. I'm a surgeon at the Institute for Advanced Reconstruction, and I specialize in the microsurgery of nerves. Pudendal neuralgia is a compression of the pudendal nerve. So what that amounts to is the pudendal nerve is in someone's pelvis. It's the nerve that goes to their genitalia, to their perineum, to the anus, that whole entire area down there. And pudendal neuralgia is where that nerve gets entrapped. So it's very much like carpal tunnel is in the wrist. So in the wrist, carpal tunnel syndrome is where the median nerve, which is the nerve to the first 3.5 fingers, goes through a leathery tunnel in the wrist. If for some reason that tunnel is tight, the nerve gets compressed, and you can get symptoms. The symptoms can be numbness, pain, weakness of grip. It's analogous in the pelvis. The pudendal nerve goes through what's called Alcock's Canal, which is also a leathery tunnel in the pelvis, and it can give people perineal symptoms. And those symptoms can be pain, they can be numbness, they can be tingling in that area, even to the point of what we call kind of dysesthesia, where it's oversensitive. It can give people bowel symptoms, and incontinence of urine, incontinence of stool, sexual dysfunction, what we call dyspareunia or painful intercourse. Any of those things can occur with pudendal neuralgia.
So first, when a patient contacts IFAR, they are put in touch with one of our IFAR specialists. Now, these are trained individuals who know specifically what to ask for to form a preliminary diagnosis based off of what you are calling about. In the case of pudendal neuralgia, you'll have a series of questions that you'll receive, and then we will ask you for other documentation that goes over what other procedures and testing that you've had. From this initial screening, we'll determine if you're a candidate to continue the process in determining if you need to be worked up further for pudendal neuralgia.
What we do surgically is we give the nerves more room if they're swollen. So if they're traveling through a tight leathery tunnel, we may French bread the top of the tunnel so that the nerve has room again and it doesn't get pinched. So we think of pelvic outlet compression syndromes kind of all as a spectrum. Pudendal neuralgia, piriformis syndrome, they're all kind of part of the same basic process. The pipes are clogged. Is it clogged at this elbow or that elbow or both a little bit? It all depends. So that's a full spectrum.
People come to IFAR because we're responsive and we really care. We're very invested in our patient outcomes, and I don't think there's a single surgeon that doesn't take it very personally if they have a patient that doesn't do well. And we're incredibly invested in getting them to the right person, even if it's not us. So there's no hesitancy within us to pick up the phone and say, you know what, you need my colleague and he's up the street, let me get you in right away to see him. And then they don't have to wait to make other appointments or to go through that process. We can shortcut everything and get them to the right place.
Regarding pudendal neuralgia, it's fairly rare. We see a lot of it because we see a big swath of the patient population that has this. That being said, it's probably also significantly underdiagnosed, and it's probably more prevalent than people think. But the most important thing is it's still one of the less common reasons for people having pelvic pain. They shouldn't jump to a conclusion that they have pudendal neuralgia just because they have pelvic pain. Patients first need to see at least their primary care physician to make sure there's not other issues. It is essentially obligate that a woman see a gynecologist before seeing us, and men see a urologist before seeing us, because those problems are much more common than the things that we see. Nonetheless, if a patient has been screened through their primary and through the first kind of level of specialties, if their etiology or the cause of their problem is still not clear, or if things are starting to point to pelvic outlet syndrome, pudendal neuralgia, and so on, we're happy to see them. And then usually our workup will start with a good history and physical, and then work from there.
Just call, take 15 minutes and talk with myself or Dr. Elkwood or anyone else. That's it. If you have someone that can help you hear it out, you can always say no. I like to say if a barber offers you a haircut, you don't have to get it cut. You can come back, and you can always come back if you decide no. But just talk and see, because the worst thing is to have a treatable condition, let time pass, and now a treatable condition became an untreatable condition because too much time elapsed.